So we have had the month of October has been Black History Month, and the title of our seminars is Global Communities, Local Challenges, Partnership Solutions. So welcome to this session today with us. And we're just going to start with some housekeeping. So the session will be recorded and the recording has started. So just to make you aware of that, and we will share the session with those who can't make it today. Please do feel free to write comments in the chat. Feel free to turn your cameras off to save on bandwidth, and please do mute yourselves if you're not speaking. You can raise your hands, but I won't be able to see, but hopefully one of my teams will be able to let me know. We do have a Q&A function, and you're more than welcome to put your questions in that function. We're going to have a Q&A session at the end. So I'm going to start by talking about our health protection work, and then I will pass over to Chris. We do have a post-event survey or feedback form as well, which would be really grateful if you could fill out. It'd only take a minute or two to fill out, and it will help us to improve our seminars and presentations in future. So just a few aims for the session. We really want to just give you some insight on the current local work streams that are undertaken by both our teams. So there's recently one team that is now split into two. So I will talk through health protection and Chris will talk through addictions. We're going to go through some statistics and data that cover a variety of health protection issues, including vaccination rates amongst high-risk populations. And this is, of course, going to be in the context of people's ethnic backgrounds. I'll talk through infection rates, I'll talk through access to oral health services and various other health protection issues, focusing on ethnic backgrounds. And Chris will also talk through the aims of the addictions team's presentation. But the key thing is to raise awareness and shine a light on some of the health inequalities being experienced by some of our residents and citizens in the city, and how we in the public health team are addressing these. So this table just sets out some of the work that we do, and we will go into each of these things individually. I'll touch briefly about the Health Protection Forum and how we work to that. I'm going to focus on some immunization and vaccination work that we do. We do also do lots of work on screening. Our main focus in health protection is to have communicable disease control and prevent the spread of diseases and infection through our citizens and our city. We have a focus on migrant health, and we also work on things like air quality. We're preparing for cold weather right now as we go from autumn into winter, and making sure we have the resilience to get through the season. And we work on food safety and standards and oral health. So a whole variety of things that we work on, which we will not be able to touch on today because I'm only going to have about 20 minutes or so to give you highlights of the work we do. This slide here is very busy, and I did not have any intention of going through it in any detail, but it's to provide you with more information for when you have time to have a look and see the kind of work that we do as a team here in the public health team. So let's get into it, shining a light on inequalities, starting with immunisations and vaccinations. Well, I felt it was appropriate to start with COVID, because we know that back in 2020, it was the start of the COVID pandemic that shone a light on the inequalities that were faced by various ethnic groups as they were overrepresented by getting COVID, overrepresented by getting ill, being hospitalized, and also dying from COVID. So here we are 3 years later on, and this table is a very basic table that gives a guide of the trend we have of COVID uptake by ethnicity in Birmingham. So this describes, because there are lots of different ways of measuring statistics for COVID uptake, this one describes the evergreen offer that we had up to March of this year, where any citizen who wanted their first COVID vaccinations were eligible to go and get those. And we know that we still have over 400,000 citizens that are not yet vaccinated. So in terms of ethnicity, we can see in the table that the groups of the highest vaccine uptake rates are the white British, white Irish groups, where they have 75 to 80% uptake. And then we go to the Asian and Asian British groups, which are down to 66%. And then with Black Caribbean, 42, and Black British, Black African, 39%. And then the groups with the lowest uptake rates are mixed groups that are White Caribbean, down at about a third of people taking up the offer of vaccination. I'm going to talk through this table now. It's slightly more complicated, but essentially the reason that we're talking through this one is to talk about the intersectionality of deprivation and ethnicity. So we know that some of our most vulnerable and underserved groups will also be living in the most deprived parts of Birmingham. So when you look at this table, you've got the IMD, which is the Index of Multiple Deprivation, and what it does is it tells you the IMD1 are people who lived in the most deprived areas, so our most deprived and underserved populations. And then 10 are the least deprived or the most affluent parts of the city. And 99 is just where they didn't have it's unknown. So the trend that you can see here, when you look across the top of the table, you have the statistics for the national, so in England, and then you have the Midlands, and BSOL is Birmingham and Solihull, and so on for the whole of the West Midlands patch. So the general trend is that those in IMD1, so the most deprived and the poorest, have uptake rates around 50 to 60% across the board. So about half of those who are eligible for the vaccine, for the COVID vaccine, have taken up the offer and had the vaccination. But if you look on the other end of the scale at IMD10, so the most affluent and the richest of the population, they have uptake rates of about 80% across the board. So roughly a 30% difference between the poorest in terms of uptake and the richest. So the most affluent are also the most protected by the vaccination and the least likely to get ill, end up in hospital, etc. So we just wanted to touch on that. And then moving on from COVID, we have flu uptake rates. So of course, flu has been around a lot longer, and we've got established flu vaccination, seasonal flu vaccination services. So here we have two tables. The table to the left describes flu vaccination uptake in those aged 65 and over by ethnicity, and the table next to it describes those aged 16 to under 65 in a clinical risk group. And the trends that you can see here are that when we look at ethnicity groups, the white British population have the highest percentage uptake at 83.6% in those aged over 65, and the lowest uptake is in the Black British Caribbean groups at 48.5%. And if we look across the table for those aged 16 to under 65 in a clinical risk group, we can see that the uptake rates are much lower than for those in the over 65s groups. But again, the trend remains that by ethnicity, white British, you have the 54.4% at the highest uptake, and Black British Caribbean at 28% uptake at the lowest rate. So this trend continues to follow through COVID into flu. And then if we look at these data at flu uptake by deprivation, you can see again, just a reminder, 1 being the most deprived and 10 being the least deprived or the most affluent. We've got 3 charts here of the Midlands commissioning region, and we have some of our most vulnerable groups. So we've got 65 years and over, 16 to 65 and at risk, and then pregnant women. And again, you can see that the trend follows that those who are most deprived, so the poorest, have the lowest uptake across the board for each of those groups. And it's particularly worrying in pregnant women who we know are really vulnerable to being very ill if they do get flu whilst pregnant. So we're trying to do everything we can, not only to improve the uptake in these vulnerable groups, but also in the poorest and also in certain ethnic groups, because we can see this trend ongoing. I wanted to take a minute to talk about measles and MMR. So the MMR vaccination is given twice. So MMR1 is measured at when a child is 24 months old, but can be given from a year old. And MMR2 is given when a child is 3 years and 4 months, but is measured at 5 years. So the difference between MMR1 and 2 is that 1 gives you 95% protection when you're aged 1 onwards, and then MMR2 gives you up to 99% protection. So again, looking at these tables, it provides the MMR uptake rates across the West Midlands, and you can see that Birmingham is highlighted there, and Solihull as well. Unfortunately, Birmingham does have some of the lowest uptake rates that we have across the board, and this data comes from Cover, which is 2022 to 2023 data. So for MMR1 at 24 months, we're at 83%, and then MMR1 at 5 years is slightly better at 88.5, but MMR2, so the second vaccination at 5 years, we are at 76%. And to put this in context, what we're trying to achieve is herd immunity, which is when a vaccination rate is at 95%. And the reason that's so important is if we get 95% of the population vaccinated, then we stop the spread of the disease, and we also protect those few people who cannot get vaccinated for whatever reason. This is particularly important because we are at a high risk of a measles outbreak at the moment. There's been an outbreak in London and in Stoke, and actually we have had a diagnosis of measles very recently in Birmingham. So we're at high risk of an outbreak. So when we talk about our seasonal vaccinations and COVID and flu, we also have to keep in mind that we should be getting people to recognize the importance of having their MMR to protect them from measles. The reason this is so important is because we did have a measles outbreak in Birmingham in late 2017. There were 8 confirmed cases that started at the beginning of the outbreak, but there was a significant number of people affected, as you can see from the slides. Luckily, there were no deaths reported, but it was a serious outbreak, and it was within our Roma community. So what did we do about it? Well, we've done lots of things since. There's a MMR health inequity initiatives that were introduced to improve vaccine uptake. We've explored things like expanding MMR outreach, so having pop-up clinics, mobile vans, visiting people in their homes to make sure that they're vaccinated. We have COVID access and inequalities funding amount of money that's provided to reduce inequalities, and we've explored using that to promote MMR alongside COVID vaccinations. We have been working with our colleagues, some of them who've joined us for this webinar in the behavioral sciences team, to do some work about addressing this issue and trying to get MMR uptake increased in various ways. So listed some of those things that we're doing. We're working with communities such as the Black African, Black Caribbean communities as well, to try and learn more about what the blockers are to getting vaccinated, and to just understand things from a culturally sensitive perspective as well, and to utilize data to generate community and geographical level insights, so to find out where the issues are, and so that we can then target them appropriately. Okay, so just coming off measles, I'm just going to touch on a few other things, and then I'll be handing over to Chris. So tuberculosis, I thought it was interesting to pick this up because it's one of the areas where we did find data in terms of ethnic groups. And we found that between 2019 and 2020, the number of TB notifications and rates for people born outside of the UK decreased in general across Public Health England centres, as they were called then, except for the West Midlands, which actually saw an increase. And you can see there's a table that explains the numbers of people by ethnic group, and then by the numbers that have been affected, but more importantly, the rate, because the rate tells you the numbers per 100% of the population. So you can see there for UK-born ethnic groups, those with the highest rates were the Black other with 19.5 per 100,000. And when you look at the non-UK born numbers, when you look at the rate per 100,000, it would be in the Indian and Pakistani groups where we saw the highest levels. So we need to look at these data and see whether these trends are continuing and what's causing them. I thought I'd put this slide up just to show how actually we do still work quite closely with our colleagues in the addictions team, because so many things that happen in health protection, there's crossover with addictions as well. So this table just describes TB in ethnic groups and talks about some of the social risk factors involved in some of the diagnosis. So we can try and use these risk factors to find those who are affected. And things like drug misuse, alcohol misuse are listed amongst these risk factors. So very briefly on HIV, just to talk about HIV diagnosis rates, again, we have these data in ethnic groups. So again, it tells us the trend that we're getting used to seeing, which is that in certain groups, you have a higher proportion that are represented in diagnosis. So for HIV, there's 53.1% of Black African people were diagnosed at a late stage of infection. So the reason that we're measuring late stage infection is because we're doing everything we can to get diagnosis earlier and before people are symptomatic or presenting in hospital, because then at that point it's getting very late to save them and the infection is well established. However, if we pick it up before the people become symptomatic, you can have a really good quality of life. So again, this chart just describes by ethnic group what the HIV late stage diagnosis is. And as you can see, Black African and Black Caribbean are overrepresented in those charts. Just going to skip along because I know that time is ticking. Again, this just talks about HIV diagnosis rates, and it says that proportionally, diagnosis is overrepresented in some of the Black African and Black Caribbean groups. I'm going to touch briefly on oral health. And again, this is a table that shows access to oral health services by ethnicity, and it states from 2020 to this current year. And the trend is, again, that in certain groups you have lower access, so lower access of people of certain groups being able to go and see their dentist and have their appointments. So avoiding getting caries and avoiding having poor oral health. So again, work to do there to see why these trends continue this way. So we've shone a light on some of these data, the ones where we could find data by ethnicity. So what are the partnership solutions and what are the things that we can celebrate? So what we do know is we need more complete and more accurate and more timely data, particularly ethnicity data, so that we can get more information to be able to explain why we're finding these trends. That's not to say that there's nothing to be done in the meantime, because the research and the evidence show, and we can see with the data that we do have, where the issues lie. So certainly there's work to be done, but we do need to have more data sets. We certainly need more long-term sustainable community engagement. That's essential in order to respond effectively to outbreaks. As I mentioned at the start of this, in 2020, we saw certain ethnic groups overrepresented in hospital and dying from COVID. And yet, when we look at the uptake rates for the vaccination, we're still seeing those same groups underrepresented when it comes to taking an intervention that will protect them. So we need to understand what is going on still. Myth busting is really important. There's still this misconception about MMR and autism, which is leading to many groups of people not going and taking up the offer of the MMR vaccine, which anyone can have at any age. And we really do encourage people to go and get their MMR vaccination if they're not vaccinated. So we are here to provide information on evidence and facts, and do some myth busting. And also improving access to healthcare services is really important and something that we're looking into with our communities as well. So lots of work going on. I'm not going to read out each of those things. I already touched on the MMR Behavioural Sciences project that's happening with some of our communities, the Gypsy and Roma community specifically, and colleagues already had a webinar on this earlier in the month, and I think are here in this webinar with us, some of them. So yes, lots of work happening across the team and across our citizens in Birmingham. So partnership solutions for the health protection team. We work together with various partners, not just our communities, which is really, of course, very important to have our community engagement, but also with partners like UK Health Security Agency, who do a lot of work in preventing the spread of diseases and other health protection issues as well. We have our ICB, the Integrated Commissioning Board, and our colleagues at NHS England that we work hand in hand with to make sure that relevant data is available, is captured, recorded, shared. And this is also so we can hold colleagues to account and each other to account to make sure that we're doing the right thing. So we use the data to hold the health protection team and our partners to account. And we do this actually via our health protection forum, which I touched on at the beginning of the presentation. So the health protection forum does reports to our health and wellbeing board. And we have that line of governance and accountability to the Health and Wellbeing Board to let our leaders know what we are doing in terms of health protection and protecting the health of the citizens of Birmingham and beyond. We also amplify key messages to the right audiences. So we go via local authority teams and services, community networks, contacts, and we have things like the webinar that we're doing right now. We've had one recently for educators in schools. We've got an all-staff webinar coming up this week as well. So we try and make sure that we're spreading the key messages to all the right audiences. And then just to finish up on partnership solutions for the whole of Birmingham City Council, there's a lot of work that is being done and much to be celebrated. We have Everybody's Battle, Everybody's Business, which is our bold strategy on tackling inequalities across the city and within Birmingham City Council itself. We have Black Year, which our Director of Public Health, Justin Varney, spoke on in our very first webinar for this entire series, where we've had the partnership between ourselves and Lewisham Council, doing really groundbreaking and fantastic work together and continue to do so. And then we have Creating a City Without Inequalities Forum, which is a partnership subcommittee of the Birmingham Health and Wellbeing Board as well, that is also focused on reducing inequalities in the city, including health inequalities. So those are some of the things that we're doing, not just within our team and within the public health division, but right across Birmingham. And I think that I'm very much out of time, so I'm going to hand over to Chris. Thank you.
Understood, both by personal tutors and by students. Let me see if I can just.
Thanks very much, Fumi. I think my slides are just coming up. Fumi, if you can let me know when they appear, that would be great.
Yes, I can see them.
Great, thank you very much. So thanks, Fumi, for the introduction. And as Fumi said, the health protection team and the addictions team were until relatively recently one large team covering all of these work areas together, which is why we're sharing this presentation. We are now two separate teams and forming distinct work plans. But as Fumi said, there's a lot of overlap and a lot of joint working still going on. So during this webinar, I wanted to, or during my half of the webinar, I should say, wanted to just explore some of the details around alcohol use and harms, particularly relating to our different ethnic groups. And using the alcohol harm paradox as an example, which I'll explain shortly. And through that, we want to emphasize that it's important to dispel myths that individuals' ethnicity is a protective factor in health harming behaviour. We shouldn't make assumptions that people from different communities, different population groups have different health behaviours, particularly related to alcohol use and or substance use, which is also within my team. We want to help you think about The importance of language. There's a lot of debate around hard to reach and underserved communities. Hopefully I'll be able to persuade you that it's we shouldn't view people as hard to reach, that we need appropriate services to reach out to communities and ensure they get the support they need. And to discuss the importance of culturally appropriate services as well, to make sure that we're doing everything we can to meet the population's needs in our super diverse city. And obviously throughout this, we'll be looking at the inequality that people from different ethnic groups experience and what we need to do to reduce that. Before I move on, I just wanted to remind people, if you have got any questions, please submit them in the question and answer option on the top of the screen, or if you've got any comments as we go that aren't questions, please put them in the chat. So alcohol harm and dependence. We have in Birmingham a relatively recent drug and alcohol strategy, which is our 000 strategy. It's called 000 because it has 3 very ambitious purposes, aims. So we're looking to achieve or work towards 0 deaths due to drug and alcohol addiction, 0 overdoses due to drug and alcohol addiction, and 0 people unable to receive support when they need it. Now we know they're very deliberately ambitions, not targets, because we know it's going to be very difficult to actually achieve those, but we are going to do everything we can to work towards those aims. And that's the strategy is backed up by a very comprehensive needs assessment. And when you get these slides, you'll have links to those documents. So the needs assessment looked at all of the inequalities that we experience in our city around drug and alcohol use. And on my slides, there's a lot of information that you can have a look at when the slides come round. I just wanted to pick out a few points on the needs assessment for you. So it's important to recognise that the consequences of substance use, drugs, alcohol can be exacerbated by socioeconomic inequalities. And we know that there's a lot of complexity amongst our population in Birmingham across a number of different characteristics and interrelationships with socioeconomic inequalities. And it's important for us to understand the different inequalities which people from different ethnic groups experience and how that impacts on their use of and harms from alcohol during this presentation about alcohol and drugs more generally. The needs assessment found clear inequalities between different characteristics. Of relevance for today is clear inequalities between different ethnic groups. That's inequalities in use and inequalities in harm, which all needs to be addressed. This final point is repeated throughout the rest of the presentation. So services need to understand those inequalities. They need to understand the communities and the population groups that they are there to serve. And it's important that we don't get misled by different assumptions that people might make about different ethnic groups. So what is harmful drinking and alcohol dependence? Harmful drinking is where there's a pattern of alcohol consumption that causes health problems directly related to the alcohol. And alcohol dependence, this is a definition from NICE guidelines. It's where there's a craving or there's a tolerance that develops to alcohol, high levels of alcohol use. And there's a preoccupation with alcohol and continued drinking despite harmful consequences being observed, such as liver disease or mental health concerns as a result of alcohol use. Okay, so there's a lot of unmet need for alcohol use. So this graph on this slide identifies the level of the proportion of individuals in treatment. So the higher the bar on the graph, the more of the population are in treatment for alcohol use. And around 8-9 years ago, it was around 21% of people with need for alcohol support were in treatment. In the more recent data in 2018-19, that had dropped to around 12%. So we're going in the wrong direction, and there's a lot of unmet need out there for our communities in Birmingham. And it's important to recognise not only do we need to stop and reverse this, but there's a difference between Birmingham and the England rates as well. So in Birmingham, we have approximately 83% unmet need for alcohol support at the moment. And across England, more generally, that's currently around 79%. So it's important for us to understand not only where we are in relation to the rest of the country and regional neighbours, but also to understand the inequality that sits within that number in Birmingham's populations as well. This slide provides a bit more detail on that breakdown and on the proportions of our population groups that are engaged currently in our treatment services. So in Birmingham, for adults, that is those services are provided by Change Grow Live, or CGL, people may know them as. For children and young people, that's provided by Aquarius. And that we work very closely with them, and they work closely with each other to ensure that there's continuity of support. So as you can see from this slide, individuals from a white background make up the majority of clients for alcohol support, followed by Asian communities and Black and then mixed communities. And we've also got a faith breakdown there as well, to understand the difference between different faith-based communities. It's important to recognise that these data are a combination of a number of different things. So this is a combination of levels of alcohol use in the population, or perceived levels, but importantly, it's a representation of which communities are engaged in treatment, whether that is because treatment services are doing outreach to engage with people, or whether it's behaviours within communities that might impact on how easy it is for people to engage in treatment services. So just to reiterate, this is people in treatment. This is not necessarily representative of the level of need. So what is the alcohol harm paradox that I mentioned at the start of the talk? So this is an infographic from a Canadian study, but I think it helpfully represents in a slightly easier to use format what the alcohol harm paradox is. So the harms people and the effects that people experience from alcohol use are dependent on a number of factors, and professional papers talk about the individual and the environmental factors. The alcohol harm paradox means that where you've got the same level of alcohol use in different population groups, you quite often see different levels of harm. So harm is not always, or not only, a result of the level of alcohol use. Harm can be a result of a number of environmental factors that people from those communities also experience. So the same level of alcohol use can cause different levels of harm in different communities, and that's important. So as you can see on the chart, on the bottom part of the chart, you've got lowest income is the darker circle and the darker bar on the left-hand side, and highest income is the more orangey coloured information on the right-hand side. and that's looking at the hospitalizations per 100,000 people in the community. Like I say, this is a Canadian study, but the alcohol harm paradox applies everywhere to a different or similar extent. So it's important. The size of the circle on those charts is relative. So you can see that for the lowest income, and this is where the alcohol use is the same. You've got 411 hospitalizations per 100,000. So that's suggesting that there is more harm from that level of alcohol use. And amongst the highest income group, it's only 166 hospitalizations per 100,000 population. So that's identifying a clear impact of the alcohol harm paradox, where the same level, when it's adjusted, the same level of alcohol use is contributing to different harms amongst more deprived communities. And we see this amongst different ethnic groups as well, and I'll come on to that on another slide. So there's a really useful paper that Alcohol Change UK, which is a policy-based organisation that does a lot of work and campaigning around alcohol use and support. They did a rapid evidence review, and they've identified a number of factors related to ethnicity. They looked at patterns of problematic alcohol use and harms amongst Black and minority ethnic communities. There's lots of information in that slide. So just to pull out some key points, services and healthcare services in particular should not assume that certain ethnic groups abstain from alcohol use based on the ethnic group or the religious community that people belong to. There's no single best way to deliver services. It's important that services meet the needs of people, whatever they are. There's a lot of hidden use within hidden alcohol use within communities, particularly amongst women, and it's important to recognise that. And that co-design of services is really important to ensure that we have successful services. Lots of these messages I will come on to again, and I think they're repeated on that slide, so I won't go through those again. This slide is important, and I just want to draw to your attention a couple of points on this slide. So what you've got on this slide is the percentage of people aged 16 and over who are drinking at hazardous, harmful or dependent levels by ethnicity and sex. So the dark blue line is the data for men. The yellow bars are the data for women, the lighter blue for the general population. So as you can see, the white British community experiences significantly higher rates of harmful and hazardous alcohol use and consumption. And the bars for the white community are greater because of that. But what I want to draw to your attention is the difference here between men and women. So you can see there's approximately 30% white British males experience harmful or hazardous drinking, compared to 14 or 15% for women. So there's a clear difference, roughly half the rate for females to males. The important point to note here is how that is different for the Black community as it's described in these data. So you actually see slightly more, a slightly higher proportion of Black women experiencing harmful alcohol use compared to Black men. And that's important to understand the difference, the intersectionality for different communities and different genders. That's represented again in this infographic, and you can have a look at this in case this version is more helpful for you when the slides come round. So this is again representing that Black women experience high levels of harmful alcohol use compared to black men, whereas in the white population it's very different, and services need to recognise and understand that. So this this chart and the one on the following slide just identify the size of the problem and the relative importance of the problem. So I've circled the relevant data here just to highlight it. So we have far more alcohol specific deaths in our white community than all of the others. But what's important is the age standardized mortality rates in the right-hand column. And here you'll see that our Indian community experience a slightly higher rate of alcohol specific mortality than our white population. So it's important for us to understand that the number of service users and the number of people in the population with alcohol use is not necessarily representative of the proportional levels of harm that they might experience. And it's, again, important for health and support services to understand that. That was for men, and you see the same for women. Different community ethnic groups on this slide having similar harm ratios. So there's an issue with data and biases within data. We're dependent, as Fumi said, on the data that we have available. Sometimes it's not always what we would want. It's not always as complete as we would want. And it's important that we both design services with data in mind, but also we design services based on the data that we have available, and ensure that we understand from our communities what their experiences are, so that where there are gaps in data, we can ensure that we're doing as much as we can to meet communities' needs. I won't go through these in a lot of detail. Again, you'll have these slides to refer to, but it's important to understand that with the alcohol harm paradox, the harms that people experience, as I've said before, are not necessarily just a result of the levels of alcohol use within those communities. And it's important that we identify that and understand that and have services that can meet their needs. And there's lots of further information when these slides come out for you there on that. So what is being done nationally, and I'll come on to locally next. At the moment, there's a consultation that opened up in the last couple of weeks. This is the government consulting on some new alcohol treatment and dependence guidance that they're looking to bring out. So I would really encourage people, when you get a copy of these slides, please do, if you're able to, click on the links, have a look at the consultation. And it's really important that we make sure that the guidance that the government are currently drafting and that will come out shortly identifies the needs of different ethnic groups and the inequalities that different groups experience, and ensures that services meet those needs appropriately. So that's important to look out for. This the culturally appropriate alcohol services toolkit. This was a result of a piece of work that was done in the West Midlands over the last couple of years, led by Sarah Burwood, who was previously with the Office of Health Improvement and Disparities. So she worked with a number of organisations and local authorities across the region to develop this toolkit. And we've not yet found that this has been nationally published, but we can share a copy. So again, if you would like a copy of this toolkit, do email us on our team email address, and we can send copies out to people. And that's really important to help ensure that services are developed in a culturally appropriate way and deliver services that are suitable for all of the populations they need to support. And like I've said on previous slides, and I'm saying again, there's no single solution. It's alcohol use and alcohol harms, and socioeconomic status and ethnicity, and a number of other interdependencies and interactions mean that it's very complex, and that services need to design how they deliver support and treatment to people around the needs of the population that they're there to serve, and that they involve those communities in service design, and that we base it on the need that the communities identify as out there. So what's being done in Birmingham? Like I said, we commissioned CGL, and they work very closely with another charity called Kick It, who have a specific focus around engaging with some of our diverse communities across the city. You can find out much more information online. We can give you links to Kick It and CGL, and you can see how they're doing as much as they can at the moment to ensure that services are doing a lot of outreach and engagement with our diverse population. I've already touched on the needs assessment on a previous slide. I think, again, just to remind you, one size does not fit all, and we need to empower communities and ask for their help in ensuring that what we design and what we commission and what we put in place meets their needs, and that they have a role in helping us to do that. They're best placed to tell us what they see as the challenges and what they need as a result. So in summary, as Fumi said, data needs to be better and more complete, but we mustn't stop doing things just because we would always want more data. We have a lot of data about inequalities already. More would be great and would be helpful, but it's important that we continue making progress. We need to make every contact count. We can't assume that whether health or social care or local authority services are where they're engaging with people, they're not making assumptions based on ethnicity or any other characteristics about the level or the problems associated with alcohol use. And it's important that every contact is used and